Teaching Hospital. And thank you all for joining the session today. Our speaker today is, I'll have the honor and pleasure to introduce Mr. Hussam Nasser. He's a well-rounded vascular surgeon. He was one of the leading surgeons in aorto-occlusive disease in Heartland Institute in Birmingham. And he's one of the people treating complex aortoiliac disease. He's one of the executive committee in the BSIT committee and one of the driving force behind the success of that meeting. And now he's currently practicing in the National Guard in Saudi Arabia. Today he will be joining us to discuss about aortoiliac occlusive disease. I want to start in time so everyone will have enough time for questions. It's a big topic and there's a lot to discuss.
Thank you very much for the very kind introduction. Just want to make sure, can you all hear me well?
Yes.
And you can see the screen. Can you see my slides?
Yes, we can see the slides.
I can see your slides, yes.
Brilliant. Thank you very much, everybody. And thank you all for this kind invitation and the massive effort that the Sudanese Association of Vascular Surgeons has put in to share the knowledge and the training across the board. So we're going to talk today about the management of aortoiliac occlusive disease. And before you start talking about the management, you have to talk about the indications for intervention. And for me, those are the main indications: lifestyle limiting claudication, and I only offer that only if the patient stopped smoking. Obviously, CLTI is an indication whether it's stress, pain, or tissue loss, and sometimes we do offer it for patients with active atheroembolization of an aorto-occlusive lesion. And when you talk about the indication for interventions, you've got to ask yourself, why are you offering the intervention? When do you offer it and how? So when we talk about why, the therapeutic goals of this intervention, you have to think about your patient as a whole and how frail is the patient, the comorbid status and their symptoms. And obviously, you've got to decide depending on the disease severity and distribution, because we all see it. Sometimes we have patients with severe disease and minor symptoms and vice versa. And you've got to tailor your intervention to your patient's needs. And again, you have to decide between you and your patient, what are you intending to achieve? Is it symptom control? Is it preservation of function? Is it preservation of limb? Is it healing of tissue loss? And sometimes we do it to preserve an underlying conduit or vessel, or to keep that bypass going. As with any vascular intervention, the big question is open better than endo? And this is the argument all of us use, say why open is better than endo, is that the aortobipham graft is more durable than the iliac intervention or iliac endovascular intervention. But the problem is that, as with most vascular research, we're always asking the wrong question. And this is the wrong outcome to look at. We don't really care about patency in occlusive disease, whether it's aortoiliac or infrainguinal. And the primary outcome for most of the trials should be amputation-free survival and quality of life. And I'll come into that in more details in a bit. So if you asked which is better, open or endo, the answer is simply, we don't know. And I'm not going to waste my time going through all the small trials done by single centers or a few centers. But the big question, we know that the answer is still not there. And this is why the NIHR has recently approved and supporting the EVOC trial. And hopefully the EVOC trial will answer that question for us. And essentially the EVOC trial is almost identical to the BASIL trial, but in the aortoiliac segment, and it's comparing open versus endovascular revascularization for aortoiliac occlusive disease. And you can see that it's going to be a massive trial involving a lot of centers in the UK. But the big thing is that finally a trial that's asking the right question. And the primary outcome of this trial is amputation-free survival. And again, the main secondary outcomes are going to be quality of life and the cost and further cardiovascular events. And as I said, it's identical to the Basel trial, but for the aortoiliac segment. But because we don't know, when you're asked what is the best intervention, I think the best intervention is what is best in your hands. And that's why you have to be aware of your local unit's outcomes and what you and your unit are comfortable doing, and if your outcomes are comparable to those of the national standards. And this is what we've been taught, and certainly what I've been taught when I was training in vascular surgery, is that if you look at the task classification, and by the way, this is, I absolutely hate this classification because I can never remember it. And if I'm asked about the task classification, I always have to refer back to this chart. And it's not easy to remember. But what we've always been told is that task A and B, endovascular, C and D are open surgery. But in all fairness, what I do these days is that I almost always have endo as my first option, except for that distribution of disease circled in red. So if one has a flush occlusion to the renals, this is the time where I'd actually prefer open surgery to endovascular. Because when I plan my intervention, I always say to people, if I'm going to do it, I always give myself a room under the renal arteries for an open bailout if everything goes down or the endovascular intervention occlused. And when we're talking about endovascular intervention, you have got to plan it correctly. And I can, in my head, I divide the planning in those three steps: is the workup, the access, and the devices. And the workup, again, obviously we cannot do CPET studies in those patients because if you're going to preserve this intervention to those with severe claudication or CLTI, then you cannot really do the CPET. But you have to really understand the patient's physiology, frailty and functional state. I always do echoes and lung function tests before the intervention. And obviously you need to do a thin slice CT scan to understand the anatomy and to plan your intervention accordingly. And in terms of access, we talk about access and people talk about the upper limb access, radial, brachial, axillary, subclavian, and femoral. And I've tried them all. And I can tell you after experience that those are the only axes that I use. And if I'm going to use the upper limb, I almost always use the axillary, and I do a surgical cut down for that. We in our unit and other colleagues have had really, really bad outcomes after trying to do this through the radial or the brachial. Particularly if you're going to do aortoiliac intervention, you need to use large size sheaths. So if I'm going to come from the top, I always use axillary cut down. And this is why, as part of the workup, my CT always involves the arch vessels. So it's a full aortogram. Just in case I need to come from the top, I can plan my axis as well. And if you're going to come the traditional way from the femoral artery, this can be either percutaneous or surgical. And percutaneous is preserved to those who have good landing zone in the aortoiliac artery with no outflow disease. So this is the Achilles heel of aortoiliac intervention, is that your outflow is bad, your procedure is going to fail. And this is why you have to be absolutely obsessive about your outflow, particularly the common femoral and the profunda femoris, as most patients will have multi-level disease, particularly if they come with CLTI. And if you're going to do surgical cut down and you're going to improve the outflow, you have to create, or in my opinion, one has to create a landing zone in the external iliac artery. And I'll show you in a bit how to do that. And you always have to improve the outflow. And this is what we call adjunct procedures. So if you're going to do a femoral endarterectomy, do it right. And it's a very extensive femoral endarterectomy, well above the external iliac artery. And the reason for that is that you do not want your stent crossing the inguinal ligament. And I almost always use a long patch into the PFA if required, because the profunda femoris is the main runoff vessel for this procedure. We know that SFA disease is very common, so you cannot rely on the SFA downwards as your outflow, and you know the profunda femoris is what's going to keep your intervention on your stents patent long term. However, if you're dealing with multi-level disease and you're going to deal with the aortoiliac segment as well as infrainguinal disease, and you want to do a bypass, I always say do a profundoplasty with a patch and then do the bypass. And the problem is that because if you do the endarterectomy going into the profunda and then you do a bypass, the angle of your bypass is going to be awkward. Don't know whether you can see. I'm just going to draw it to you. So if you're going to do a patch here, you can do the patch and then you can run your bypass normally like that. However, let me just take this. However, if you're going to do an endarterectomy and straight use your vein graft or your conduit as a bypass, the bypass is going to lie in a very awkward angle because it's going to come from here, from the profunda. So it's going to start like that. Let me just, so it's going to start like that, and then it's going to have a steep angle like that to go medially for your bypass. And that angle can cause the further failure of your outflow of your bypass. So if you're going to consider doing a bypass, do the patch first and do your bypass from your patch. And I'm sure this is going to be one of the points of discussion at the end of this presentation. Oops. And when we're talking about devices, you got to think, how are we going to cross? Are you planning to cross through and through? Is it going to be retrograde? Is it going to be coming from the upper limb? And I put a big question mark in front of the add-back devices because I almost never use an add-back device. If I fail from retrograde, I have a very low threshold for coming from the top. And think about your equipment, your sheath, your catheters, and your wires. And if you're using aortoiliac stents, your sheath are almost certainly going to be more than 6 French. And the next thing is the devices, the stents. You're going to think of which stents are you going to use for the aorta, for the common iliac, and for the external iliac. And there's a big debate, and I'm coming to that in a minute, but I keep it very simple for myself. I use cover stents for everything. And I think it's the safest, particularly if you're dealing with calcified disease and you're planning to crack the vessels. So I use cover stents for everything. And for the aorta, the common iliac, I use a balloon-mounted stent because you need accurate, millimeter-accurate deployment in those areas. And in the external iliac, you need something more flexible because the external iliac artery is a tortuous, mobile vessel. So I use self-expandable. And even with endovascular intervention, there are still a lot of unanswered questions. Do we use covered or do we use uncovered? Do we use STIRAB if you're going to be dealing with an aortoiliac segment, or do you use parallel stents? And again, we don't know. And this actually got my attention because there was a talk on Vascupedia, which is an online platform that I recommend to everybody. It's got fantastic sessions there. But they were discussing this exact question: is that which stent do we use for the aortoiliac segment? And as you can see, there is absolutely no consensus as to what to use because there's no evidence to suggest what is best. But regardless of your choice, always have cover stents on the shelf if you're going to embark on treating aortoiliac disease, because they do rupture and you will need a cover stent if that happens. And the next question is that do we use the SERAB? The SERAB technique is obviously the one where we use an aortic stent and then put two iliac stents from it, so essentially reconstructing the normal anatomy of the aorta, or do we use parallel stents? And again, there's no real good answer to this, and this is our work from Birmingham, and we have always used parallel stents. We've never used CERAB, and our results are really comparable to the CERAB. But the big highlight of our study here is not whether it's better or worse or the same as CERAB, but is that the amputation was not associated with target vessel revascularization or stent graft patency. We actually came across patients that, or a lot of patients, that the limbs were saved, and we got them through the initial phase of their tissue loss or rest pain or whatever, and the stents got occluded eventually in the future, but that did not translate to limb loss. And this is why I say that the question of patency is always the wrong question. It's all about amputation-free survival. So even if the stent occludes in the future, sometimes it doesn't matter. But what we've realized is that, again, durability should not be a question in those patients, because if you're truly dealing with CLTI patients, particularly those with tissue loss, and those with tissue loss are highlighted in red, you'll see that in 2 years, 50% of those patients are dead. So again, durability is not the big question here. And I say to people, be extremely, extremely obsessive about planning. I plan my aortoiliac disease like I plan my EVARs. I sit down, you can use whichever software you want to use. I personally use Terra Recon, but you need a 3D reconstruction software, and I plan it exactly as I would plan EVAR. I measure the distances of the occlusion, I measure the angulation, particularly if I'm planning to preserve the internal iliac artery, for example. I always plan the angles at which I will be able to see the iliac bifurcation. I check the IMA. Am I going to cover the IMA or not? If I'm going to cover it, I always check the celiac and the SMA and make sure that they are patent, and the covering of the IMA is not going to affect that. I decide which stents I'm going to use and how long they're going to be. And I also decide whether I'm going to do a femoral endarterectomy or not. And obviously, in this case, we did do a femoral endarterectomy. So I'm going to go through some cases because I think a lot of the discussion will come from those presentations. So the first one is a 71-year-old man who came in with an acute and chronic limb ischemia on the right side. He was initially claudicated at 100 yards and presented to us with a 2-day history of rapid onset of short distance claudication. Background is what we expect of a patient who comes in with CLTI. He's a heavy smoker, hypertensive, ischemic heart disease, diabetic, and COPD. And they come as a package, almost. And this is the CT scan. You can see in the cross section here. And if you can look at this is not contrast. This opacity is pure calcification. And you can see from the 3D reconstruction how calcified the vessel is. And even the left side, you can see the SFA and the profunda, how calcified they are. So this case was done by one of my colleagues, and I'll show you what not to do. Is they did the femoral endarterectomy and went on to do the iliac stent. But I said, please, if you're going to do a femoral endarterectomy, make sure that your femoral endarterectomy is quite extensive. Going into the profunda, which they have done, and you can see they've done a beautiful profundoplasty here. But what they have not done is they have not taken the endarterectomy above the iliac ligament, the inguinal ligament. And you can see the radiological landmark for the inguinal ligament is the pelvic brim, which is there. And you can see the endarterectomy stopped here, and that is the femoral head there. The endarterectomy stopped short of the inguinal ligament, which meant that when they put the stent, You can see that's, don't know whether you can see it clearly, but that's the end of the stent here. The stent starts from here and ends there. But you can see that means the stent crossed the inguinal ligament. I don't like that. Although I think we've had this discussion in the BSET meeting before. Some of my colleagues do say that crossing the inguinal ligament is not an issue. But I still don't feel comfortable crossing the inguinal ligament with a stent. This is another case where, again, we had to do a femoral endarterectomy and iliac stent. But you can see that here, the femoral endarterectomy goes well above the inguinal ligament because that's the pelvic brim there. And you can see that the endarterectomy went above the inguinal ligament, and we created a landing zone. And that's, I don't know whether you can see it, but that's the end of the stent there. The stent is above the inguinal ligament as we've planned it. And again, this patient had a nice profundoplasty. And the big question people ask again is how do you do it? Do you puncture the patch? Do you do the endarterectomy and then go on the side of the patch? And it's taken me a while to come up with the best solution. And the best solution in my hands at the moment, and what I do these days, is that I do the femoral endarterectomy and profundoplasty. And I also do sort of a limited remote endarterectomy of the SFA to create an SFA stump. And you can just about see here, that's the SFA stump. So I close the patch. So I put the patch here, close the patch completely, and I create the SFA stump and I puncture the SFA without obstructing the patch. And what's good about that is at the end, when you close that hole that you created for your sheath access, you can clamp the SFA without disrupting the flow to your stent and risking the stent occlusion. And you can just see that's the point where I punctured the SFA. So we go to another case, a 73-year-old female with a CLI of the leg and severe rest pain. And again, she's got a background of heavy smoking, diabetes, COPD, CKD, and ischemic heart disease. So on examinations, she was quite a malnourished lady. I remember her very clearly. She weighed 35 kilograms, which at the time when my boy was 10, she was lighter than my 10-year-old boy. Very ischemic left foot, no palpable pulses on either side, symptomatic only on the left side. So the plan was to admit her to hospital, analgesia, urgent CTA, and work up for intervention. And this was her CT angiogram, and all the white that you can see there on the reconstruction, that's all calcification. She has tortuous, and this is the worst combination, is tortuous, occluded, calcified iliacs. And you can see this gives you a better feel of disease. So you can see she's got a very calcified aorta. She's only symptomatic on the left side. Remember that, because that's going to become relevant towards the end of this case presentation, or for this particular patient. So you can see her right iliac system here as calcified and occluded. You can see that. And on the left side, very tight common iliac here, very calcified. And as we go down, it's a very calcific disease. And you can see that's the iliac bifurcation there. And she's got a bit of an internal, but the internal occludes after that. And all her external is just a lump of calcium. And as we go down, you can see again, that's her common femoral artery, just white. It's occluded and white with calcium. So she was discussed in the MDT, and after her workup, it was decided that she's not a candidate for open surgery, and she's for a left femoral endarterectomy and iliac stenting on the next available list. And this is another point that we can obviously discuss at the end of this talk, is that in those frail, unwell patients, I like to do the absolute bare minimum. So if they have aortoiliac occlusive disease and they're only symptomatic on one side, I just focus on that side and just do the bare minimum to get that patient out of trouble. Because you know that the longer you keep the operation, the longer you keep the patient in the GA, the worse the outcome is. And those patients, actually what they need is a quick in and out operation. And this is exactly what we did, is that I took her to theatre and I did a femoral endarterectomy, which was the easiest part of the operation because it's a very slim lady, arteries in your face. So we did the usual femoral endarterectomy, fundoplasty, patch. At the time, I used to. I don't know that there's background noise. Yeah, thank you. So at the time, I used to puncture the patch. So I punctured the patch and went up. Crossing the lesion was not a problem. You can see I've crossed the lesion with the wire, but I could not cross anything else, not even a 3mm balloon. So I've exchanged my wire to, low profile wire with the 018, and I still could not pass anything through that tight, tortuous, calcified iliac disease. So the next thing we did is that I came from the top, so exposed her infraclavicular axillary artery and puncture that, and after surgical cut down into direct vision, and came from the top. And you can see her aortic arch there. And then after I came from the top, you can see my sheath. That's the end of my sheath here. And you can also see, because her disease is so calcified, you can see the outline of the calcification, because that's the outline of her vessel there. So I came from the top and then snared. I don't usually use a snare, but I actually come from the top and then cannulate the sheath and then grab the wire from the bottom. Saves a lot of money. Plus, you, in those cases, usually don't have enough room to open your snare. So you just cannulated the groin sheath, the femoral sheath from the top, and then grab the wire and have a through and through wire. And this is called body flossing. And this is a very, very useful technique. And I learned it from my colleagues who do a lot of aneurysmal disease. And they do this if we have aneurysmal tortuous disease and you want to safely pass a large device, you do this body flossing and it gives you the most stable platform. So with the body flossing, you just grab essentially a wire coming from the top, a wire from the bottom, and you pull on the wire either side, and that gives you the stiffest sort of platform you can ask for. And then managed to pass a 4mm balloon, created a channel so I can pass my sheath and deploy my stents. And this is exactly what we did. So I don't know whether you can see it clearly on your screens here, but we managed to get through and through. As I said, this is probably the pelvic brim is about there. And this is the viabahn. So deploy the viabahn, which starts from here. You can just see the dots of the viabahn, and it goes all the way down, and that's the bottom bit of the viabahn. So we've nicely deployed the viabahn. And then you can see it clearly here. That's the top of the viabahn. That's the bottom of the viabahn. And then took this picture. And at that point, I thought, brilliant, almost done. I've only got this chunk of calcium to deal with in the common iliac. And I've got to just sort out this bit of the viabahn with a balloon just to expand the viabahn to its actual diameter. And which brings me to another point, is that in all patients where I put an iliac stent, I almost never use anything less than 8mm. And this is because I'm a surgeon. Most of you in this meeting are surgeons. If you're thinking about open intervention, if you're going to use an iliofem bypass, you'd never use a 6mm Dacron. You'd always use an 8mm Dacron. And I stick to the same principles here when I'm doing endovascular intervention, is that I use 8mm viabahns. And then at the top, as I said, we use the balloon mounted stents. So this is exactly what we did here, and we use the in this case, I used the V12 for atrium. And then took the final shots and said, brilliant, that is looking all good. And all I need to do is just balloon that bit. And I did that. And you can see the balloon here. And as soon as I did that, the anaesthetist from the top said to me, what did you just do? And this is why when you're doing iliac intervention, always inform your anaesthetist and keep in touch, because what happened is, I don't know if you can see it, is this. So I said I always use cover stents to avoid the risk of rupture, but be aware that it does not completely eliminate that risk. It just reduces it, because this patient had so much calcification that when I ballooned it, the calcification tore into the fabric of the viabahn and the viabahn ruptured. And this is why you have to have all the kit around you. So we just quickly ballooned the iliac and just put another viabahn inside that viabahn. And obviously I did not balloon it again. So end of the day, felt that, yeah, challenging case, but we did very, very well. Very proud of myself. And I was just writing the notes in the coffee room. I got a call from recovery saying, patient is shouting in recovery and she's got very severe leg pain. And of course, I assumed that it's going to be the leg that we treated, which is the left leg. And I went to recovery and she had an ischemic right leg. And I was trying to think to myself, how could this happen? She had an occluded iliac system on the right side. How could I have made it worse? But I did, and I've learned my lesson ever since. So you can see this is the baseline angio for this lady. You can see the disease there. Obviously, on the right side, which is now in recovery, she's screaming with pain with, or in pain with, is completely occluded. So how could I have made it worse? And the reason I made it worse is that the right leg was relying on those collaterals and the collaterals from the internal iliac. So all of those were eventually feeding right leg. And I used a cover stent and I covered that little bit of blood flow that was going to the right side. And I thought to myself, there's no way I was going to go through all that hassle again with the right side. So we took her back to theatre and we did a fem-fem crossover. A couple of years later, I think that was a discharge surveillance scan, which is usually in 2 years, and it's all working fine, patient symptom-free. So the next case is a 77-year-old male, the 2-day history of pain, paresthesia of the right foot. This is the thing, is that usually we get a lot of those patients who are essentially sitting on their chronic disease, and suddenly they have a occluded branch or something that we're relying on, or they have an in situ thrombosis and they come with acute symptoms. Again, he had no femoral pulses on the right and weak pulses on the left, and the usual background history of those patients with CLTI. And this is the picture. So I have, over the past few years, stopped doing kissing stents for patients with flush occlusion of the iliac disease, because the stents we have these days, the balloon-mounted stents, you can land them and deploy them millimeter perfect, and I usually can deploy them just at the origin of the iliac disease without compromising the other side. But occasionally we come across those cases where the disease actually extends well into the aorta, and obviously you cannot do that. And you're planning to do an intervention in this case, you'll have to land your stent, if you're doing it endovascular, I'm saying that you have to land your stent above that disease into the healthy segment of the aorta. And this is where the debate is, are you going to use a CERAP technique or are you going to use the parallel stents? And it doesn't matter. You use whatever you want to use. You use whatever you're comfortable with, as long as you cover the whole disease segment. But whatever you decide to use, the iliac stents, whether it's serap or parallel stents through and through, the most important step is that when deploying the parallel aortoiliac stents, they have got to be absolutely parallel and absolutely at the same level. So you cannot deploy one stent above the other. And what happened, and we've learned this the hard way, is that if they are well aligned, the top stent inevitably always slightly bends and occludes the lower stents. So the top stent will remain patent, and you'll eventually occlude the stent that was deployed lower down. This is why you have to deploy them exactly the same level. Even if you're doing a serap and you're deploying those stents within the single aortic stent, you have to deploy them at exactly the same level. And this is the end result. So you can see that they're both deployed at the same level here, same level there. And we managed to preserve the internal iliac on the left side and not on the right. I think it was occluded anyway. And this is the other option of when dealing with occlusive disease on one side, is that if you cannot cross the lesion through and through from retrograde, so you can see that this is my sheath here. So I think in this case, we did a femoral endarterectomy as well. And this is the end, the tip of my sheath here. I think we tried and tried, and we could not cross this occlusion retrograde. So it's quite lucky. This is one of the easy ones, is that you do have a stump on the common iliac here, because that's the bifurcation. So we crossed the bifurcation, went up and down, and then crossed the occlusion. And I usually pass the wire, and as I said, I cannulate the sheath and then grab the sheath through and through, and then pass the wire up, and I do the procedure as always. So we used to come a lot from the top, particularly if the occlusion is, let me just delete this. So what happens is that if the occlusion sometimes is flush at the bifurcation, if you think that's the vessel, so if the occlusion is flush there, sometimes it's extremely difficult to get an up and over and engage your catheter here and cross this lesion, and you have to come from the top. But since the introduction of the steerable sheaths, I think I've never needed to come from the top for this particular indication. Obviously, if the occlusion is in the aorta, then I do come from the top. But with the steerable sheath now, we just get the sheath up there and just shape it. It's a steerable sheath, so shape it like a rim catheter, and then pull the sheath down and engage on the origin of the occlusion, and that gives you a very stable platform, and you can always cross it from the other side. So as I said, the cerebral sheath have almost eliminated the need to come from the top to cross an iliac occlusive disease. Again, this was the end result of the intervention. So, because I know there will be a lot of questions, particularly about the technicality and what can be done and not done in those cases, I thought I'll keep my talk brief and give you plenty of time to discuss and ask questions. So, in conclusion, endovascular first treatment for aortoiliac occlusive disease is a viable treatment strategy. Obviously, if your unit is familiar with it and you know what you're doing, techniques and strategies and equipment have improved, and we've got satisfactory medium and long-term outcomes. Be aware of your own unit results, and I think that's very important. And as you saw, that these days the disease has changed and the complexity of the disease has changed. And a lot of the time, you do need a lot of support and help from your colleagues, particularly like the cases I presented where you're coming from the top and you have to cannulate the sheep and bring it down from the bottom. Let me just see what's. Sorry, just that I'm on call today and oh dear.
Apologies for this
I'm,
brief.
so- I'm sorry about that. So, in conclusion, that yes, you have to be aware of the limitations of yourself and of your unit, and if you need help, just ask for help early before it becomes too late. Thank you very much, and I'll open the floor for questions because I'm sure there'll be a lot of questions.
Thank you, Hussam, for this amazing presentation. It was very informative and very useful. I think Mr. Ayman has a question.
Yes. First of all, I would like to thank Mr. Hussam Nasr. Thank you so much for accepting the invitation from CDFS and enriching us with this very informative presentation and sharing your experience with us. So I would like to, I'm Ayman Ahmed, I'm a vascular surgeon here in the US, and I would like to, get your thoughts on a couple of questions. Number one, you mentioned the paper from Birmingham and the comparison between the syrup versus the parallel graft. Unfortunately, I didn't get a chance to go over that paper, but did that no significant difference between the two exist even when you had to raise the bifurcation more than 2 centimeter? Because I think that was what the syrup advocate calling for. Like if you have to raise it above 2 centimeter, then syrup will have more durable outcomes. So I don't know if that's still maintained that results. Yeah.
Yeah, so we did not compare, and we just published our results. We only do the parallel stents because we think it's quicker, it's cheaper, it's safer. And yes, we do raise it all the way up to the bifurcation if needed, to the infrarenal segment if needed, and we've had no issues with that. And again, it's just what we did is it's just compared to the published results of the SERAP, and yes, they were comparable regardless of the level. But we did see stents occluding, and another thing was astonishing is that despite the stents occluding, patients still preserve their limbs, and one did not come with the other. But what's more important, and we saw this in the basal trials as well, in those patients with CLTI, is that we're not really looking for durability here because those who are presented to us with tissue loss, and in our paper, we only focus on patients with CLTI, so rest pain and tissue loss. And those who had tissue loss did not live more than, 50% died within 2 years. And I keep reminding everybody, I said to them, this disease is worse than cancer. So just think about what you're trying to achieve when treating those patients. And I think what we're trying to achieve is that we're trying to palliate them and allow them to die with their limbs preserved.
Sounds good. I'm sorry, and you mentioned what kind of stent you guys use in Birmingham to raise the bifurcation?
So we do it exactly the same way every time. Without any change. So what we do is that we build from the bottom up. We always build from the bottom up. So we start with the via bands at the bottom if it's a total aortoiliac occlusive disease involving the aorta, common and external iliac. So we start from the bottom external iliac. So we do the via bands, and it has to be 8 millimeter plus. And then we top it up with the balloon mounted stent. We used to use the V12s. The V12s are much cheaper. This is why we used to use them. And now with the VBX, we only use the VBX if we need long VBX because, the VBXs go to as long as 79, but the atriums of the V12s only go to 59. So instead of using two atriums, now we've started using the long VBX because it eventually it will work out much cheaper if you use one rather than two stents. So yes, so balloon self-expandable stents at the bottom, which are the Vyvanse, and balloon-mounted stents at the top, which are either atriums or VBXs.
Question. So one thing I found to be the most challenging when I'm doing these cases is the re-entry, especially when you have a long occlusion, including both the common iliac and external iliac, and you're coming retrograde from the femur after you finish your endarterectomy and you want to recanalize the occluded common and external, and now you're in the distal aorta. So the re-entry, so I don't know if you have any tips or tricks for that. I mean, what I use every now and then is the Pioneer device. I mean, it's the, ultrasound augmented re-entry, but it's not available all the time. So I don't know if there's any tricks you do have, sometimes, yes, come from the arm, but I don't know if like you're already kind of pressed from below, if there's anything that you kind of recommend.
So no, as I said, is that when I was giving my talk, is that I said, using the outback devices is put a question and exclamation mark next to it, because I have never used it, and I have a very low threshold for coming from the top, because the last thing you want is dissect the whole aorta and then find yourself at the renal level, because that is an absolute disaster. So I have a very, very low threshold coming from the top. And the way we do it to come from the top is that we do surgical exposure. And if we know that we're going to be dealing with, complex occlusive disease, what I do is expose the infraclavicular axillary artery, and then we pass a 10 French Ansel 1, 45 millimeters. So 10 French Ansel 1, 45 millimeters, that will take you into the descending aorta. And that sheath does not move. And because what you don't want is that you don't want sheath moving in and out of the arch, disturbing that area and increasing the risk of stroke. And then inside that, we use the 6 French Rabi from Cook, which is 90 centimeters. That's quite long and gives you a lot of maneuverability. And even if you're dealing with severe distal aortic disease, you can still get it to reach that area. So that gives you sort of coaxial support. So you have the 10 French, the 6 French inside it, and then we come from the top. And if you've developed your femoral endarterectomy at the bottom, even if you go subintimal, because you've done your femoral endarterectomy, and this is why I am very obsessive about lifting the endarterectomy plane above the inguinal ligament. Because if you're above the inguinal ligament, your endarterectomy is above the inguinal ligament. If you go down the iliac, you know that you're always going to exit at exactly the right level, which is the level of your endarterectomy. And then we do them through and through, and then do the rest as normal.
Thank you so much. That's very helpful. Thank you.
No problem.
Thank you. I think Mr. Awuda has his hands up.
As always, thank you, Mr. Hussam, for this nice presentation, straight to the point. I would like to discuss just only one point. I know that the shockwave is out of the IFU for the aortoiliac disease. However, I read a few case reports from Canada and United States, and they gotten a very good outcome. So I just want to know if you had such experience.
Yes. So your question is, use shockwave exclusively and not put a stent, or use a shockwave to improve the compliance and then put a stent?
I meant that the shockwave exactly at the aortic bifurcation is out of IFU. So there is a few.
Yes.
Yeah.
No, I know, but the thing is that because what people are advocating, they've pushed the limit now. People are advocating, and they're showing quite promising results, that for calcified iliac disease, they use a shockwave, and they just use that and not put a stent. I have not personally done that. I have used the shockwave for the iliac disease to improve the compliance of the vessel if I'm really concerned about vessel rupture, and then put a stent. And I have to say that I am, and I'm still am, I was, and I still am quite impressed with the shockwave and how it improves the compliance of the vessel. But have I had the courage or the confidence to use the shockwave exclusively and not put a stent? No, not yet.
Thank you.
Yeah,
Thank you so much.
yeah. If I may weigh in, because yes, definitely we use a lot of shockwave here in the U.S. and my practice has been the same. Like what Mr. Hassan mentioned about preparing the vessel rather than using it as standalone therapy for the iliac. The only time I do that if I'm gonna come back for something else, but usually it's for those calcified with circumferential calcification. And anecdotally, what I noticed, it decreased the risk of rupture. Like since I start using it, I haven't had any iliac rupture, which I had before using the shockwave. Like especially those like circumferential calcification, we start ballooning them, and then the vessel ruptured. So it's been very helpful from that standpoint. So, and I think, but even like when I talk to the rep, they're not advocating for using it as a standalone therapy. They're usually advocating it as a prep device or balloon for the vessel, especially for those high risk products.
Yeah, no, I totally agree with you. But I know that some of our colleagues, particularly in Europe, now have started using it exclusively. But as I said, there's not enough data, and I don't have enough confidence in that way of treating aortoiliac disease. And I've used it a lot actually in patients with aneurysmal disease and with underlying occlusive disease. So as an endoconduit. So before we just used to stick in a stent, but now, particularly with calcified vessels, I shockwave it, put the stent, and then use deliver the EVAR device.
Thank you. I think Mr. Tariq Barakat has a question.
Thank you very much. Wallahi, it was such a high quality presentation. Thank you very much, Mr. Hassan.
Thank you.
The only thing which I found with this iliac occlusions and severe disease is that when you want to do an endarterectomy, when you have multi-level disease, is to control the iliac. And I think people have to be very wary of this, because I grew a lot of gray hair in some cases of these iliacs
Yes.
when there is no good control, because the iliac can be like a lead pipe, essentially.
Correct.
And if you want to clamp the vessel will rupture, and then you are really in deep trouble. And I think is that, I don't know what you think, but sometimes if you are not able to control the vessel, I think you might even need to abort the procedure because you will not be able to do it. Because if you try, you say you open the femoral and try to pass a balloon, and it just, things are not, you don't have definite control. I don't know what you think, or if you have any tactics or something like that. I have been in such situations.
No, absolutely. It's one of the scary situations, is that when you lose control of the femoral vessel and you just cannot clamp it. And you're right, people do lose patience because of that exact scenario. Obviously, the best case scenario is that if it's calcified and totally occluded, because you don't even need an inflow clamp for those patients. The worst are the very calcified vessels, very calcified iliacs, but with a lumen. And in those cases, I always have and if I'm anticipating that, I have a wire coming from the top ready to balloon. And usually, just because the lumen in those patients is usually very, very tiny, very small. It's 3 millimeter, max 4 millimeter lumens. So I put an 018, if there's a lumen, I put an 018 wire through that and be ready to deliver my 4 millimeter balloon for control if required. And the 4 millimeter balloon will just be enough to close the lumen and not rupture the calcified iliac. Yes, once you've got control, it's fine. The ones I struggled with, in all fairness, is not the ones with the inflow control, because with using that tactic, I almost always get around it. The one case I abandoned was not a calcified common, it was a calcified profunda, and I could not just get a clampable area in the profunda, and it was just back bleeding endlessly. And this is the one case I abandoned.
Yeah, I had similar situation as well. Now, I'm sorry, just one extra thing. Regarding the external iliac,
Yes.
You put a covered stent. Now, what I worry with usually is that these patients are I mean, they have got global ischemia, and when you are putting like parallel stents, so most likely your IMA might go. You put a covered stent and you might cover the internal iliac, which is might be perfusing some of their profunda through some branches and things. Is it that not too much, you think, or what do you think of that?
We have not seen any problems with that, and people do talk a lot about IMA and covering the IMA. If you're covering the internal, you're going to get bowel ischemia, and we did not see it. And I know that people talk about chimney stents for the IMA, and I have to say that I really do not like this practice, because if you're going to chimney the IMA for bowel ischemia, it means that you're worried about SMA and celiac disease, because if your celiac and SMA are normal, then you should not really worry about your IMA. And in those case scenarios, sorry, there's a bit of echo.
Please stop
in
the background noise. Mute yourself if you're not talking. Sorry.
So if I know that I'm going to cover the IMA and I'm worried about the bowel ischemia, I address the celiac or the SMA prior to doing that. I do not chimney the IMA. So treat the SMA and then cover the IMA, or treat the celiac and then cover the IMA. But relying on the IMA chimney to perfuse the bowel, to me, just goes against all advice and all European guidelines. And if you look at the European guidelines, they always advocate revascularization of the SMA.
I fully agree with you. Thank you very much, Mr. Hussam, again, for this really great presentation. Thanks.
No, you're more than welcome. It was my pleasure.
Now, I know this topic is a vast topic, and Mr. Hussam is a great speaker. But I'm aware of time constraints, and I'm aware Mr. Hussam is on call as well. So again, Mr. Hussam, I extend my thanks and gratitude for this great presentation.